I'm Dr. Beth Rappaport from Mount Sinai Medical Center. This instructional video will review the indications, contraindications, techniques, and potential complications in performing a lumbar puncture. A lumbar puncture is performed for either diagnostic or therapeutic purposes. It is essential in establishing a diagnosis of CNS infections, including meningitis, encephalitis, or myelitis. A diagnostic lumbar puncture can also be useful in diagnosing inflammatory processes such as multiple sclerosis, an acute idiopathic demyelinating polyneuropathy, also known as Guillain-Barré syndrome, and vasculitis. Subarachnoid hemorrhage may also be diagnosed with lumbar puncture. Additionally, CSF may be analyzed for cytology or specific proteins to diagnose other conditions, such as malignancy or paraneoplastic syndromes. Metabolic conditions may also have findings in the CSF. A therapeutic lumbar puncture can be performed to relieve symptoms of a few specific causes of increased intracranial pressure, such as cryptococcus meningitis, idiopathic intracranial hypertension. It can also be used to deliver medication, such as anesthesia, chemotherapy, antibiotics, or contrast dye for myelography. There are a few contraindications to a lumbar puncture. Absolute contraindications include local skin infection over the site, suspected mass lesion intracranially or in the spinal cord, raised intracranial pressure with signs of impending herniation, as a lumbar puncture may hasten the herniation, bleeding diatheses, or coagulopathy that is uncontrolled. Typically, platelets less than 50,000, dysfunctional platelets, or INR greater than 1.4, are considered higher risk and would necessitate correction of coagulopathy prior to performing a lumbar puncture. Relative contraindications include raised intracranial pressure with signs of cerebral herniation, spinal cord deformities, bony deformities at intended puncture site, or suspected lumbar epidural abscess. Finally, poor patient cooperation or cardiorespiratory compromise may require lumbar puncture under fluoroscopic guidance or anesthesia. If there is any possibility of mass effect, herniation risk, or focal neurologic deficit, neuroimaging, MRI, or CT scan of the head must be obtained prior to performing the lumbar puncture. If a lumbar puncture is contraindicated, but there is high clinical suspicion for an infection, specifically bacterial or herpes meningoencephalitis, empiric antibiotics should be started immediately. A lumbar puncture kit typically contains sterile gloves, manometer, 3-way stopcock, sterile dressing, antiseptic with either an iodine or a chlorhexidine-based solution and skin swabs, sterile drapes, 1% lidocaine, 3 cc syringe, 20 and 25 gauge needle for lidocaine injection, 22 gauge spinal needle with stylet, noting that length will vary for infants, children, and adult patients, and 4 plastic collection tubes, numbered 1 to 4, with caps. In preparing for the procedure, obtain an informed consent from the patient. Explain the potential risks of the procedure, including infection, bleeding, headache, backache, and nerve injury. Explain potential treatments for these complications. The lumbar puncture is generally done at the bedside with the patient in the lateral recumbent position. Alternatively, the patient may be seated on the side of the bed, leaning over a table or pillow. Use this position if measurement of the opening pressure is not required or if the patient is unable to lie flat. Instruct the patient to curl into a fetal position and arch their back toward you to help separate the spinous processes to allow for passage of the needle. To determine the correct insertion site for the needle, palpate the superior aspects of the iliac crest and visualize a line connecting them. This line should intersect with the spine at L4. The needle should be inserted into the interspace between L3 and L4, or L4 and L5, as the spinal cord terminates at L1 or L2. Palpate for the interspace and make a small mark to use as a guide after the patient is sterile and draped. Next, wash your hands and put on sterile gloves. To prepare the patient, clean the patient's back using antiseptic solution on the swabs, starting from the insertion site and making expanding concentric circles. This should be done 3 times. Cover the area with a sterile drape, making sure the window is overlying the insertion site. It is helpful to apply the sterile drape over the iliac crest in case you need to repalpate the landmarks. For local anesthesia, inject lidocaine at the needle insertion site. Inject about 1 cc of lidocaine superficially with a small needle, 25 gauge, to create a wheal. The patient will feel a sting and a burn. Change the needle to the 20 or 22 gauge while the lidocaine begins to work. Then inject perpendicular to the skin in the anticipated trajectory of the spinal needle. With each advancement of the needle, pull back slightly on the plunger prior to injection to ensure that you are not injecting into a blood vessel. Continue this process as you advance the needle to as deep as the needle allows. While the lidocaine is taking effect, organize your equipment, open up the collection tubes, assemble the manometer, and check the spinal needle and stylet. Repalpate the landmarks as the patient may have moved slightly during the anesthesia injection. Insert the spinal needle such that the bevel is in the plane of the longitudinal fibers of the dura, and so that the fibers are spread and not cut. When the patient is in the lateral recumbent position, the bevel will be up towards the ceiling. If the patient is in an upright position, the needle should be turned so that the bevel will be towards the patient's side. Angle the needle toward the umbilicus, which is approximately 15 degrees toward the head. Use a slow, steady force to pass the needle through the tissue layers: skin, subcutaneous tissue, supraspinous ligament, interspinous ligament between the spinous processes, ligamentum flavum, epidural space, dura, arachnoid, into the subarachnoid space containing the nerve roots of the cauda equina. You may feel a pop when passing through the ligamentum flavum, followed by a reduction in resistance as you enter the spinal fluid-filled space. Once in the subarachnoid space, remove the stylet completely to assess for CSF flow. If no CSF appears, advance the needle about 2 millimeters and withdraw the stylet again. This process may be repeated. If you are unable to access a space because you have hit bone, replace the stylet completely and withdraw the needle into the subcutaneous tissue. Repalpate landmarks and then redirect the needle and reinsert. It is helpful to carefully observe the position or angle of the patient, the trajectory of the needle, and the location of the bone that has been struck prior to withdrawing, so that you may subtly redirect and reinsert the needle. This will ensure a methodical rather than haphazard approach to locating the spinal fluid-filled space. Once you have CSF, remove the stylet and attach the manometer to obtain an opening pressure. Open the stopcock valve toward the manometer. To obtain an accurate measurement, instruct the patient to carefully extend their legs fully and relax. Once the column of fluid stops rising and the measurement is noted, rotate the stopcock valve to allow the CSF in the manometer to drip into the first collection tube, which should be held beneath the manometer to catch the CSF that will be initially expelled from the device. Normal adult pressures are 100 to 180 millimeters of water. Pressures greater than 200 millimeters of water reflect elevated intracranial pressure. Detach and set aside the manometer and allow the fluid to drip directly into each tube. This usually occurs slowly, drip by drip, but if flow appears too slow, replace the stylet and rotate needle up to 90 degrees to potentially release a nerve root that is pressed up against the needle tip. Remember to rotate the needle back to its original orientation before removing it. Collect fluid in each of the 4 tubes, at least 3 to 4 cc's in each tube, unless cytology is indicated, in which case at least 5 cc's is required for best results. It is important to note that a traumatic tap may look slightly bloody or pink, but should clear with each successive tube. If therapeutically indicated, larger volumes of CSF may be removed, up to 40 cc's. Once you collect an adequate specimen, replace the stylet and withdraw the needle. Hold pressure with a piece of gauze for a minute, longer if there is any bleeding at the insertion site. Apply an adhesive bandage and clean the antiseptic off the patient's back. Laboratory studies performed on the CSF should be specific to the suspected disease process. If you suspect infection, test the CSF for cell count differential in tubes 1 and 4, glucose, protein, gram stain culture, and PCR, and consider sending for acid-fast bacillus culture or TB PCR. Cryptococcal antigen and India ink stain, fungal culture, VDRL, Lyme antibody, PCR for viruses such as HSV, CMV, VZV, EBV, HHV6, and JC virus. Normal CSF in adults has fewer than 5 white blood cells. An elevated white blood cell count may indicate infection. Different classes of organisms that can cause CNS infection, bacterial, fungal, tuberculosis, and viral, have different profiles of white blood cell counts and type, glucose, and protein that can help distinguish them before the cultures grow out. However, the ability to diagnose an organism is often limited by the significant overlap that can occur in the values. For example, in bacterial meningitis, the white blood cell count ranges from 5 to thousands with a neutrophil predominance. Glucose is generally low, less than 45, and protein is elevated 50 to 500 milligrams per deciliter. Opening pressure may also be elevated, greater than 200 millimeters of water. Viral meningitis has white blood cells from 5 to 2,000, but usually less than 250, with a lymphocytic predominance, but may initially have a neutrophil predominance. HSV may also have red blood cells greater than 5 per milliliter. Glucose is often normal, and protein is elevated to 20 to 200 milligrams per deciliter. Opening pressure is likely to be normal. If you are performing the lumbar puncture to investigate inflammatory conditions, additional studies may be sent. For example, in multiple sclerosis, the specimen should be evaluated for cell count differential, protein, glucose, oligoclonal bands, and an elevated IgG synthetic rate and index. The cultures and viral PCRs should be negative. In AIDP, or Guillain-Barré syndrome, the typical findings are elevated protein with a normal CSF white blood cell count, known as the albuminocytologic dissociation. This occurs in 80 to 90% of patients with GBS 1 week after the onset of symptoms. A subarachnoid hemorrhage must be distinguished from a traumatic tap, which usually contains 1 to 2 white blood cells per 1,000 red blood cells, and red blood cells that diminish in subsequent tubes, and will have a clear supernatant upon centrifugation. If malignancy is the concern, fluid should be sent for cytology and specialized testing such as flow cytometry and other stains. Lumbar puncture is a relatively safe procedure. In a small percentage of patients, complications may occur. The most common complications are backache, seen in up to 1/3 of patients, and headache in 10 to 30% of patients. A post-LP headache is attributed to low CSF pressure due to a persistent dural leak, causing traction on pain-sensitive structures. The headache characteristically worsens when the patient sits or stands and begins 24 to 48 hours after the procedure, but can last up to 2 weeks. A post-LP headache is usually treated initially with oral analgesics and can be treated with fluids and maintaining a recumbent position. However, neither of these treatments has been proven effective. If severe and refractory, a blood patch may be used to seal a dural leak. Performing a lumbar puncture using the smallest possible spinal needle, such as a 25 gauge, has been associated with a decreased risk of headache. However, this is not always practical for diagnostic taps and should only be used for anesthesia. Transient radicular pain has been reported in 13% of patients and only rarely persists. Bleeding may occur locally at the site of the needle insertion and infrequently can lead to an epidural hematoma, which may need to be evacuated surgically. Paraparesis has been reported in patients receiving anticoagulation. Infection is a rare complication but has been reported. Brain herniation is a possible complication but is far less common with the routine practice of neuroimaging, MRI or CT scan, prior to performing the lumbar puncture to rule out intracranial mass or mass effect. In summary, a lumbar puncture may be crucial to the diagnosis and treatment of your patients. In this video, I have reviewed the indications, contraindications, techniques, and potential complications in performing a lumbar puncture. With practice, you will be able to perform the procedure with confidence and skill. Thank you for watching this Harrison's procedure video.